All right. So today we're going to talk about EKG refreshers. So whenever we talk about cardiac related stuff, I always like to call out the potential conflicts of interest. I previously was sent to the Resuscitation Academy out in Seattle, Washington, which itself is sponsored by Physio Control and Zoll, among others. I didn't get paid directly, but they subsidized the travel to go out there and attend that training. I'm also a board member of the Ohio Cares Registry, which is the cardiac arrest registry for the state. So I always like to point those out, though, whenever I'm talking about cardiac related stuff. So today we're going to talk about, the coronary anatomy, some of the pathophysiology of a couple of disorders, and then what some of our treatment priorities are. So coronary disease is one of the leading causes of death, representing up to 30% of deaths in Western countries. If you're having an MI, you've got roughly a 12% chance of in-hospital mortality, overall a 27% chance of death, and then 41% of patients who have a STEMI end up going on to develop some degree of heart failure as a result of it. So let's real quickly kind of review the anatomy of the vessels to start with. So the important thing to note, let me see if I can get my annotation thing to work. Good. Okay. All right. So if you look up here, right here is where the aorta basically exits the heart. And that's where the two main arteries that supply your heart branch off from. In most people, there is a left main or left coronary artery branch that obviously goes off to the left. It then comes down, and we call this initial section here the left main, all right? It then branches off into this left circumflex artery, which follows kind of around the side and then down the back, as well as the left anterior descending, which is this big one here. In most people, that is the main artery that supplies blood to the left ventricle. As you can see, it usually has some of these smaller kind of diagonal branches that come off of it that can also become problematic. In some people, this left anterior descending will actually go all the way on the back and join back up with the left circumflex. But that can be rare. Moving over to the right coronary artery branches off on the right side of the aorta and basically follows itself around and then down the back side of the heart as well. And it also will have these kind of diagonal branches, this one being called the right marginal artery. But those diagonal branches then help supply the rest of the right-sided myocardium. Again, anatomic variance, sometimes that right coronary artery will end up connecting with the left circumflex or the left anterior descending. In terms of a heart attack, that's not necessarily a bad thing, because that means if you get a plug way up here, but you're connected down further, you'll get some retrograde blood flow, backwards. So that way you still perfuse portions of the heart, which is, again, not necessarily a bad thing. Sorry, I'm trying to figure out why it's not advancing. Okay, so let's very quickly talk about the valves. Obviously, the valves are there so that way blood can only flow in one direction. So over here, we've got the right atrium, all right, that then dumps through the tricuspid valve, all right? That tricuspid valve snaps shut when the ventricle begins to contract and ejects stuff out through the pulmonary valve. This is the pulmonary artery that's taking blood out to the lungs. That blood then comes back in through these pulmonary veins into the left atrium. It then hits the mitral valve. Blood flows into the left ventricle. That mitral valve snaps shut when the contraction begins, and blood gets ejected out of the aorta. And again, there's the aortic valve that snaps shut when that contraction is done. So that way the blood that just got shoved out into the aorta doesn't backfill the heart. The electrical system of the heart is really what we're focusing mostly on today. So I wanted to point out a couple of things. So your sinoatrial node is the pacemaker, so to speak, of the heart. All right. This group of cells depolarizes at about 60 beats per minute. That's why most people's resting heart rate is somewhere in the 60 to 70-ish range. Okay. Those cells depolarize the fastest. The electricity then flows from that across the atria, all right? And we have additional fibers going over here to the left, but it spreads across the atria and eventually hits the atrioventricular node, all right? That AV node is usually located in the base of kind of that right atrium. Sometimes it'll be over here a little bit in the septum. It just depends. That AV node basically takes its orders from upstairs. So the AV node, if it doesn't receive an order to, pass on a message, it itself depolarizes at about 45 beats per minute. So if for some reason your sinoatrial node gets damaged, your AV node kind of has a backup and will depolarize at 45 beats per minute. That AV node puts a little bit of a pause to let the atria finish contracting, and then they themselves are going to begin to send that electrical impulse down the Purkinje fibers, all right? These Purkinje fibers are like electrical cables. What they do is they spread throughout the myocardium, okay, so throughout the muscle, and pass the electricity on kind of all at once. We kind of want the electricity to start here at the base and then spread upwards because we're trying to squeeze the heart from the bottom up. And so by having this electrical pathway, we can really control how that contraction occurs. Now, the interesting thing about the myocardium itself is it also has a backup. So if it doesn't receive a message from the AV node or the Purkinje fibers, it itself depolarizes at about 30 beats per minute. So if you think about it, most third-degree heart blocks that you see are tending to be somewhere in the 30s range for their heart rate. And that's because the myocardium is now kind of slowly contracting. So the analogy I like to use is that when we're relying kind of on the myocardium to regulate itself because everybody else is taken out, the difference is right now I am broadcasting to all of you, okay? You're all getting the message at roughly the same time. Everything is coordinated. If I had to do this station by station, I would start here at the 87s, give the lecture. I would then have to drive over to the 86s, give a lecture, drive over to the 88s, give a lecture, drive over to Goshen 19 and give a lecture. It's much slower. It does not all happen. It's not super coordinated. Some days I may decide to go to a different station first and then go to a different one following that. So it really benefits the body to have this electrical pathway because we can control that conduction and that contraction much better. So when we talk about an EKG is just simply measuring electrical activity, all right? We've got various lead placements, and we basically have the ability to divide the heart both front to back as well as top to bottom, all right? And that's where those two discs that you see there are. The important thing to remember about every EKG is whenever there is an upward spike on the EKG, that is electricity flowing towards that lead. If electricity flows away from that lead, that causes a negative spike, okay? So with the precordial leads and the traditional leads, we're now able to basically pinpoint exactly where an injury may be occurring. EKGs can tell us a lot of information about a bunch of things, but obviously today we're really only talking about the STEMI and dysrhythmias. So now that we know about the lead placement, it also makes sense that this would correlate with the arteries, because now that we know the direction that the various leads are, we can now infer based on that where potential injuries are. So we'll start with everybody's favorite, the inferior. So 2-3 and AVF, that tends to indicate a STEMI to the right coronary artery wrapping around potentially to the back. As we move forward onto the precordial leads, V1 and V2 are typically your left anterior descending, okay? V2, V3, V4, those are considered your anterior STEMI. Those are also part of the left anterior descending. The difference being it's further down that left anterior descending, okay? So if you see your maximum ST elevations at V4, that's probably where the blockage is most pronounced. As we move further along, we get to the lateral leads, V5, V6, AVL, and 1. With those, that's a lateral MI, and that tends to indicate more damage primarily to the circumflex artery that goes and wraps around. So now that we know where the EKG findings are going to show up, we now know what artery is going to be impacted. The reason that's important is because those arteries supply sections of the heart. And we know that if, somebody is having an infarction in 2-3 and AVF, that's primarily affecting the right side of the heart. The right side of the heart is very pressure sensitive. And so if we give them nitro and it drops their pressure, we may cause a cardiac arrest. Similarly, if we're having a septal MI, a V1, V2 MI, that may take out parts of the Purkinje fibers, at the same time. And as a result, we may go into a third-degree heart block, early on, simply because that node, those fibers are not getting that blood flow necessary to do their job. This also helps the cardiac cath lab folks because the equipment is different. If you're going to go off to the left, the tubing that we send up there has a kink off to the left. If we're going to go for something on the right, we pull out the tubing that has a kink over to the right. So it really does matter that we tell them where the injury is occurring so that they open up the right equipment. So this is your traditional 3-lead. When EKGs were first started, it was primarily right arm, left leg. We've now added the right leg, and most hospitals will have this brown precordial lead called the V lead. The reason for that is it's a little bit more sensitive for breathing. That way they can get a respiratory rate displayed on the monitor. This is your traditional 12 lead, all right, wrapping around over that left side of the chest. There's also a right-sided EKG that you can do. So basically you mirror the precordial leads. So instead of V1 being where V2 here is, you start where V2 normally would be, and then you work your way just like you would on the left side over on the right. It's not as useful of a diagnostic tool unless you really want to take a closer look at that right side. Really, it's more for cardiologists. However, you may at some point in your career come across somebody that has mirroring of their internal organs. So in that case, instead of the heart being over here on the left, it's going to be mainly over here on the right. And so you would need to do a right-sided EKG and see if there were ST elevations. In those situations, that is not going to necessarily represent a traditional right-sided heart attack, and is more of the left-sided because it's a mirror image. We also have the ability to do a posterior EKG. This I do find to be somewhat useful, especially if you have a weird appearing 12 lead in the traditional sense. What you do is you detach V4, 5, and 6, and you basically carry that same arc around onto the back. And you start with V7, which you take V4 and put it there. V5 is V8, V6 is V9. And now you have the ability to see what the backside of that heart looks like. When we get to looking at the EKGs, I'll show you why that's important. The EKG itself is broken up into a bunch of different things, all right? The P wave represents the initial electrical impulse and contraction of the atria, all right? The atria then finish contracting. The AV node sends down the Purkinje fibers, the electrical impulse, and we get the contraction and electrical impulse through the myocardium itself. So contraction occurs. We now have this pause between the S wave and the T wave called the ST segment. The T wave represents kind of the end of all of the cells in the myocardium repolarizing. They're now ready to contract again, all right? So we look for changes in that area because if an area is not getting enough blood flow, that means it's not able to recharge as quickly. And so it's going to be prolonged. And so we'll get this bigger S wave as part of it. The QT interval is also important because this is when basically the myocardium is at its riskiest. Everybody knows, the whole Damar Hamlin story, but essentially what we think happened is he received a thump to his chest, okay, that happened at the wrong time during his EKG complex, and that caused him to go into VFib. It's the so-called R on T phenomenon. And what happens is if you get an electrical impulse, or in this case, a physical impulse that simulated an electrical impulse, you depolarize all of a sudden the cells that have already recharged, and those cells then begin to basically send their electrical signal to the cells that are in the process of getting recharged still. And so all of a sudden you've got portions of the myocardium that just depolarized and portions of the myocardium that are now depolarizing and again and again and again, and we get VFib. So that's not good. The other problem that can happen is in some electrolyte abnormalities, we can get prolongation of this QT interval. It takes longer for that myocardium to recharge. So if we get another P wave that then comes at the wrong time in this QT interval, unfortunately, that can put us into VFib and cause death. All right, let's talk quickly about the various types of heart blocks. We are not going to go into the complicated left-sided ones, such as left anterior fascicular block and left posterior fascicular block. To me, those are academic, for what we're doing. All right, in a first-degree heart block, we've got a PR interval that is greater than 200 milliseconds. If it's anything over 300 milliseconds, it's considered a marked delay. Most of the time, this is caused by athletics, can be a normal variant where nobody has, or somebody doesn't have any risk factors. Sometimes we'll see it in previous heart surgery or inferior MI, etc. This does not require treatment. It doesn't progress. It doesn't cause symptoms. It doesn't cause any problems. So the treatment is we just basically look at it and go, oh, okay, you've got a first-degree heart block. No big deal. There are two different types of second-degree heart block. This first one is a Mobitz type 1 or the Wenckebach. With this, we get progressive prolongation of that PR interval until we eventually just drop a beat, okay? So I want you to take a look. So let's say that this is the first. So that's our PR interval, okay? We then go on and see how it's getting a little bit longer and a little bit longer and a little bit longer again. Well, this is the longest one. It then drops the beat completely, okay? So all of a sudden, this beat does not go through the system. This is typically going to be caused by prescription drugs that we will put somebody on, such as digoxin or cardizem, things like that, that slow down that AV node impulse. Well, sometimes we slow that down too much and we get this. Generally, this does not require any treatment whatsoever. However, if for some reason somebody gets really symptomatic, and let's say that this is a very bradycardic second degree block, then atropine usually will help with that. But again, generally does not require any kind of treatment. The way I remember this, I have to have these weird things to remember things by, is Wenckebach is walking backwards. Okay. Wenckebach, walk backwards. So that way I remember the name. A Mobitz type 2 or a Hay second degree block is where we just all of a sudden drop a beat. It just doesn't go through. And this is a much different animal than the Wenckebach. This typically is going to be something structural, all right? Whether that be they had an MI, they've got a fibrosis disorder where a bunch of scar tissue is occurring within the myocardium itself. Sometimes this is just age. And what happens is you all of a sudden will just get this beat dropped. You've got the normal PR interval, normal PR interval, normal PR interval, and then all of a sudden drop, all right? This, unfortunately, will progress to severe bradycardia or a third degree heart block. And so if this is a new onset and somebody is having symptoms with it, they need to go to the emergency department because almost certainly they're going to get admitted and get a permanent pacemaker placed, while we stabilize them otherwise. Then we get into the third degree heart block. And this is probably the easiest of them to remember, which is the P waves have nothing to do with the QRSs and the QRSs have nothing to do with the P waves. So again, the AV node or the myocardium itself is what's going to be keeping the electricity going. So in this situation, this is probably around that 45 beats per minute or so. I'd have to actually count it out, but this may lead to syncope or sudden death. Oftentimes these patients are symptomatic. So if they are symptomatic with this, then they need treatment, which is typically going to be either atropine or push dose epinephrine, and then in worst case scenarios, external pacing. This is commonly caused by previous myocardial infarctions, as well as some of the AV nodal blocking drugs like the digoxin and cardizem that we talked about earlier. And sometimes this just represents somebody's electrical system failing. We will see this in the elderly where they will have an AV node that is just functioning enough some of the time, but then other times it just stops working. With these, it's virtually always admission with a permanent pacemaker being placed, regardless of whether they're symptomatic or not. All right, right bundle branch block. With the right bundle branch block, we have the right-sided Purkinje fibers that are not passing the electricity down as efficiently as, say, the left side is. So our QRS duration gets a little bit longer. We get this RSR prime pattern in V1 through V3. So in V1, we will have this M appearance, all right? So it's an M. So we go up, down, forming that M. This can be caused by right ventricular hypertrophy because there's more of that tissue there that needs to get depolarized. We will see this in pulmonary embolism as well as ischemia, since it takes longer for those cells to do their job. A left bundle branch block, on the other hand, causes this W appearance. And most of the time, we can't really actually see this little notch that's kind of in between the Q wave and the R wave. But we see this downward, up, down, up appearance in V1. It'll also sometimes look like an M in V6. So you can kind of see this little notch where it forms this little M. This can be caused by aortic stenosis, heart attack, hypertension, and then cardiomyopathy. So if the left side of the heart has gotten big, we will see this. We're not going to get into it today, but left bundle branch block used to be considered a STEMI equivalent if somebody was having chest pain, shortness of breath, and all the other stuff that goes along with a STEMI. We now know, though, that it's far more common that the left bundle branch block isn't related. at all and is not necessarily a STEMI equivalent. If you're an EKG geek like I am, you can look up something called the Scarbosa criteria. And the Scarbosa criteria allow you to more effectively diagnose an MI in somebody with a left bundle branch block. And it basically means their ST segment is through the roof. If they have a left bundle branch block with ST elevations that are through the roof, that has a high correlation with it being a true STEMI. All right, so now that we recognize the rhythms, we need to calculate our rate. We all have probably had a patient before where we've gone and done a 12-lead EKG, and it shows that they're in AFib or A-flutter. And instead of the machine counting the QRS complexes, it accidentally gets confused and begins counting the atrial complexes. And so we'll get this heart rate of 150 when you can clearly tell that the QRS complexes are not happening that fast. So it's important that you be able to calculate your own rate. And this is the thing that I have used since, I was a medical student. And the funny thing is, when I'm still trying to calculate out a rate, I literally will mark it back. And I'll be saying kind of in my head, 1 big box, 300 beats per minute. 2 big boxes, 150 beats per minute. 3 big boxes, 100 beats per minute. 4 big boxes, 75 beats per minute. 5 big boxes, 60 beats per minute. Okay. And then after that, if you get out to your 6th, etc., all we really care about is it's bradycardic. Okay. But this allows you now to kind of roughly estimate what your rate is when looking at an EKG. All right, so let's talk about some of these rhythms in some more detail. So with bradycardia, it's defined as a ventricular rate of less than 60. And if it's a sinus bradycardia, they require treatment only if they're symptomatic, okay? A lot of athletes will have resting heart rates down in the 40s sometimes. And as long as they're not lightheaded, dizzy, chest pain, short of breath, passing out, that's just their normal resting heart rate. But if they become symptomatic, they develop signs of inadequate perfusion, chest pain, shortness of breath, dizziness, they start to go into cardiogenic shock. It's really important that you obtain a 12-lead EKG to determine if this is a sinus bradycardia or a third-degree heart block. And you want to get pacer pads on, because worst comes to worst, you may have to start pacing this person. Typically what we're going to treat though with is atropine and or push-dose epinephrine to get that heart rate to come up. If you have a patient that on that 12-lead is having a STEMI, please, please, please call medical control first, okay? Because depending on how symptomatic that person is, we may tell you to just stick with medications, or we may tell you to go directly to pacing. We try and avoid pacing in STEMIs if we can, simply because the electrical impulse that we generate is going to cause ST elevations, even in somebody that is not having a heart attack. And so it impacts our ability to get another 12-lead at the hospital, with a little bit more precision. So atropine is, again, one of the first-line treatments. It's a muscarinic acetylcholine receptor antagonist. And essentially what this does is it tells your heart to ignore your parasympathetic system. And that in itself speeds things up. So on its own, it will cause tachycardia. It can cause pupil changes, cause dry mouth, urinary retention. Initial dose is 1 milligram IV push every 3 to 5 minutes until you get up to 3 milligrams. If they're unresponsive to the atropine, you can consider using push-dose epinephrine, because in that situation, it's directly stimulating the heart to speed up. And so the push-dose epi may be beneficial. It's not necessarily always going to work, but if the person is not responsive to atropine, that's what I would personally pull. If neither of those work, we're going to have to start pacing. We want to try and provide sedation if able, and I believe the protocol reads something like 2 to 4 milligrams every 5 minutes of Versed, until the patient's speech slurs or you hit, it's either 8 or 10 milligrams, I think. Once the patient is slurring, et cetera, you need to make sure that you get your pacer pads placed. Your limb leads need to be in place. That's what your monitor relies on to know when it needs to send out an impulse. Most of the time, you're going to want to start off with a rate of 60 to 80 beats per minute and at an energy of 20 milliamps. Now, I personally, recommend going up rather quickly. By definition, the folks that we're taking care of are pretty sick at baseline. And so we don't really have a ton of time to fine tune things. The textbook says increase every 10 seconds until you get to capture. I usually will do, 5 to 10 milliamps every few seconds because you'll very quickly see once you get capture. What I do is once I get capture, I turn it down until I lose capture, all right? I then slowly turn it back up until I regain capture. Now I know really fine-tuned, this is how much energy I need to deliver to get capture. But we need a buffer in there as well. So I typically will turn this up another 10 to 15 milliamps. And the reason for that is we're relying on these pacer pads. And that threshold for getting capture is in that position at that time. If we go to move the patient, those pads may spread apart and we may lose capture at that point. So by having this built-in 10 to 15 milliamp buffer, it does allow us to move the patient more easily with a little bit of comfort knowing that it's unlikely we're going to lose capture. It's important that we transport these folks to a hospital with cath lab capabilities, which for all of us is pretty much a moot point. Everywhere we go to has a cath lab. And the reason for that is because when they have a cath lab, that means they're able to do permanent pacemaker placement. So important to go there. The other thing is, if you get capture and your heart rate is 60 to 80 beats per minute, and we still have an unstable patient, we probably need to increase the rate. All right. If you think about it, somebody who is septic probably is going to have a heart rate in the, 120s or so. In that situation, we have just slowed them down to 60 to 80, and we don't have enough contraction occurring to actually maintain things. So we need to turn up that rate. So after we get capture, if they're still unstable, we can turn up their rate to a reasonable degree until we get improved stability. Obviously, we're going to be trying other things with this, like IV fluids and potentially push-dose epinephrine and things like that. But don't forget, you can adjust your rate as well. So the American Heart Association has really begun dividing things out from the traditional VTAC, VFib, SVT, et cetera, into these, broader descriptions. So the traditional VTAC is wide complex tachycardia. They then make a differentiation between stable and unstable, all right? So in an unstable VTAC, we've got a ventricular rate of more than 150 beats per minute. There's this wide QRS. We get no P waves because they're all buried within the complexes. It's important that we get IV access, obtain a 12-lead EKG if we have time, initiate rapid transport, and introduce them to electricity, okay? You need to shock anybody that is unstable. And in some cases, they may be too unstable for you to be able to sedate them. I hate doing it, but I've had to do it a few times. And I will say, I am really sorry. This is going to hurt like hell. And then just hit the button. Don't count down. Don't get into a discussion. It just needs to happen if they're unstable. Okay. Torsades is another phenomenon that will happen. And this can mimic VFib or VTAC, depending on how small the complexes are or large, and whether or not it has perfusion. What happens is you will have this sine wave appearance. So the impulses get big and they get small and they get big and they get small, et cetera. Most of the time, the patient is not going to be super symptomatic from this. And so we can give them magnesium sulfate diluted in at least 10 mLs of saline over about 10 to 15 minutes. and that tends to resolve this. However, I'm not going to ask somebody to sit there for 10 or 15 minutes with a 10 cc syringe squirting little by little. What I typically recommend is taking that 2 grams of magnesium, injecting it into a 100 cc bag of normal saline, and then infusing that 100 cc bag over 10 to 15 minutes. That way you don't have to sit there and slowly, push the thing. If somebody with torsades becomes unstable, you need to shock it. Okay. You're still going to be giving the mag, but you need to shock it. And that hopefully will get you back into a normal or better perfusing rhythm. VTAC, the traditional stable VTAC anyway, if we're able, we're going to sedate with midazolam. We then are going to synchronize cardiovert at 100 joules and escalate by 100 joules each shock until we reach our monitor's maximum. You can also try, if these are very short runs of VTAC, interspersed with, say, sinus tachycardia or normal sinus, etc. We sometimes will have you hang some amiodarone and give 150 milligrams of amiodarone over about 10 to 15 minutes and see if that helps. If, however, we have to shock them, whatever level we get to, if they degenerate from their heart rhythm following the shock back into VTAC, we don't start over back at 100. We start at what worked the first time, so that way we're not having to shock this person repeatedly. After we do the cardioversion, please try and get a repeat 12-lead EKG because we want to take a look and see what is going on. So again, wide complex tachycardia that's stable. We can, in some instances, I personally don't do this, but AHA says, instead of us going, immediately to amiodarone or shocking, if this person is stable, we can try administering adenosine, 6 milligrams and 12 milligrams. And the reason for that is in case it's this weird reentry SVT, that may fix it. I've never had this work. I don't know of anybody that has had it work. So I typically don't bother doing that. And the other nice thing about amiodarone is not only does it help with VTAC, but it also helps slow down SVT. So the amiodarone has the ability to actually fix both. So now let's get into narrow complex tachycardia. So in this situation, this is the so-called SVT that we traditionally would call it. And with this, there are no signs of inadequate perfusion, but the pulse is more than 150. Typically, these patients' blood pressures will be fine. You may even be able to see a regular atrial rate. And the arrhythmia itself is going to have a normal kind of accordance to it. So it's going to be the same every single time and not waver back and forth, kind of like an AFib or an A-flutter might do. We want to get the patient on monitor and obtain a 12-lead EKG. Once we've determined that this likely is SVT, we need to have them perform the modified Valsalva maneuver. So if you remember from a few years ago, the modified Valsalva maneuver is where you give them an empty 10 cc syringe, okay? They're sitting upright. You have them try and blow into that syringe to push the plunger out the other side. And as they are blowing as hard as they can, you quickly lay them down and lift their feet up at the same time. That has something like a 65% chance of converting them out of the SVT. And you don't even have a line in them at this point. So highly recommend it. If it doesn't work, then okay, yeah, we've got to get a line in this person and we're going to have to go probably the adenosine route. The adenosine is 6 milligrams, 12 milligrams, or 12 milligrams. And there's a technique to administering it. I'm going to show 3 different techniques, but I think you'll see which is potentially the best way of administering this. So with this, they have a wide open normal saline infusion going. They pinch the infusion, inject, and then release the the pinching of the tubing. So we get this very quick flush through. So we'll watch it again. Come on. Don't know what's wrong with it, but okay. Here is if we just left that line wide open, we don't pinch it and we just instead inject. So if you see here, we get a bigger dilution of things. And that dilution is not necessarily a good thing. With this one, this is everybody's favorite, the three-way stopcock. You know, it's kind of the theatrics of medicine where you have to get out two syringes, you have this stopcock thing that you never get to use, you have to switch quickly from one thing to another, et cetera. And look at that. We get two very small boluses that occur in rapid succession. So not the best. The reason this stuff matters is because every single cell in our body uses adenosine. If you think about it, ATP, the energy store that we use, you know, within the cell, is adenosine triphosphate. So every single cell that this adenosine is going to come into contact with, it wants to suck that up. We need to make sure that we get enough of it to the heart intact all at the same time in order for it to do its job. It's a very short-acting antiarrhythmic. It slows down SA and AV node activity, and it also antagonizes epinephrine. So if somebody is in this, fight or flight, kind of thing, et cetera, it slows down that epinephrine's responsiveness to the ventricles. It also works as a direct agonist at the membrane, stabilizing it. So if we administer this stuff and it's either too dilute or it's not concentrated enough because it's too small doses, we have problems. And so what I have gone to is I will now pinch the tubing just above the injection port. All right. I will inject. And as I am finishing up my injection, literally still pushing it, I will release the IV tubing so it flows wide open again as I'm pushing that final amount so that the biggest chunk of that is able to get to the heart all at once. All right. So if we have somebody that's having narrow complex tachycardia and they are unstable, all right, it's important that we get a history of if they're having trauma or fever. Trauma is going to cause us to have tachycardia. That's a normal response, as will sepsis and a fever. If we have somebody that is really tachycardic and they are unstable, but they have one of these things going on, we don't necessarily want them to slow down. If we slow them down, that may tank their blood pressure even more. So what we need to do is treat the underlying problem to begin with, which in both of these cases is going to include fluids. With fever, you can even add some sort of antipyretic like acetaminophen that we carry. If, however, they don't have this history of trauma or fever, again, sedate them if we're able to, and then cardiovert them. In some situations, that cardioversion is going to be as low as 50 joules, all the way up to the maximum amount per your energy, per your manufacturer's energy guidelines. All right, we've been at it for about an hour. So let's take a quick 10-minute break. So it's 9:52. So let's come back at 10:02. We've got a few more weirder dysrhythmias, and then we'll see if folks want to play Jeopardy. So we'll see you in about 10 minutes. All right, it is 10:02, so we'll go ahead and get started. Like I said, we are going to wrap up with the last few dysrhythmias, et cetera. And then hopefully people are up for playing some Jeopardy. We did this at Springfield a couple of weeks ago, and it was a lot of fun. There was trash talking, but everybody was in the same room. I think if you unmute yourself, since you're going to have to in order to answer, you can trash talk the other teams. You can come up with your own team name, that kind of thing. So, all right, so let's look at some of these weirder dysrhythmias. So, whenever we've got, some sort of an abnormal pulse or blood pressure, it's really important that we get a 12-lead EKG. These 12 leads may show us something that is unexpected. And we'll talk about a couple of these cases. So with prolonged QTC, the problem again is that R on T phenomenon. So if this QT interval is too long, a P wave may come along and occur right here when not all of the myocardium is completely recharged yet, which can induce VFib. That's bad. These are typically caused by drugs, can be electrolyte problems. We'll also see it in hypothermia, some MIs, although I've never seen it with that, and unfortunately, congenitally. There are people out there who have faulty sodium pumps on their cells, and they just don't work right. And as a result, their QTC is prolonged. And it's not a matter of if they're going to have VFib, it's a matter of when. And so typically nowadays, because we've got enough knowledge around this, we identify it early in a member of the family and can then prophylactically put defibrillators in the other affected people's chests. So there was a family where I trained that had a congenital QT abnormality, and literally the 10-year-old had a defibrillator in his chest. So kind of scary. So I want to give you a case here. So this is a patient, 32-year-old female, otherwise completely healthy, no previous medical problems, okay? She got up on a Sunday morning to go about her normal business. As she was doing stuff around the house, she was walking down the hallway and wakes up on the floor looking up at her ceiling. Doesn't remember how she got there, doesn't remember, feeling lightheaded, dizzy, anything like that. Just I woke up and I'm looking at my ceiling. So says, okay, well, I haven't eaten breakfast yet. Maybe I should go eat breakfast. So goes, eats breakfast, drinks plenty of fluids, etc., and then starts going about her day again. And this time she wakes up and she's looking at her bedroom ceiling. She's like, okay, this has now happened twice. I think I should go get this checked out. So she gets in the car and drives over to Mercy Rookwood and walks in the front door. Now, I want you to think about this. Otherwise healthy 32-year-old female who passes out before having breakfast. How much of a primrose road do we need? Yeah, this probably was just she was hypovolemic or whatever. Yeah, no. She had a QTC of 716 milliseconds. We get concerned when it's over 500 milliseconds, and we get super concerned and put pads on you when it's over 600 milliseconds. Hers was 716 milliseconds. What had been happening is this lady, unfortunately, was likely having VFib. So one of these beats would occur incorrectly and would put her into VFib. She'd lose consciousness, and thank goodness she was relatively tall. So when she'd hit the ground, it was kind of like the good old precordial thump, and would spontaneously cardiovert her out of it, and she'd regain consciousness. She very quickly got moved into the trauma bay and put on pads and got a bunch of her lab work back and ended up having significant electrolyte abnormalities that caused it. But this right here, this case right here is why you have to get a 12-lead EKG on everybody who is lightheaded, dizzy. I think I might pass out. My friend might pass out. you know, et cetera, because you're gonna catch one of these at some point. If we had gone, you know, she had called 911 and we had gone, unfortunately, some of us would have just let her refuse if she wanted without doing an EKG. The EKG in this case saved this woman's life because now we know what's wrong. Now we know how to treat it, and we can, you know, begin fixing things. So I want to show you where her P wave is. Okay. So if you look here, this right here, this is all her T wave. Okay. And look at that little bump right there. That's her P wave. All right. Now think about it. All of these occurred while she was up and doing stuff. Well, guess what happens when you're up and doing stuff? Your heart rate goes up, which means these P waves are going to be happening more and more. So any kind of an exertion was going to throw that P wave back into the T wave and cause her to go into VFib. So super, super, super important that we get 12 lead EKGs on anybody who lightheaded, dizzy, I'm going to pass out, I might pass out, I did pass out, that kind of thing, because we're going to catch one of these days. All right, delta waves. So a lot of people have heard about Wolff-Parkinson-White syndrome. It doesn't really matter much for us, but basically what happens is the person has essentially an extra electrical conduction pathway in the heart, and so it doesn't conduct electricity the normal way. So as a result, you get this slurring right here. Okay, you see that slurring of the initial uptick. Okay, that's that delta wave. And really for us, again, it doesn't really matter all that much. But if somebody with Wolff-Parkinson-White is having SVT, it can cause, when we give adenosine, some really weird dysrhythmias, including VFib, unfortunately. So always a good idea to have pads on somebody when you're going to be giving adenosine. Sorry, let me figure out what's wrong. All right, Brugada syndrome. Let me get rid of these drawings. Okay, so Brugada syndrome was first described way back in the 50s and 60s. And this type of syndrome is so prevalent throughout Southeast Asia that most of the languages down there have a single word that essentially means young man found dead in bed. Okay. These folks have a faulty sodium channel. And what happens is they will go into VFib arrest and die. This happens kind of at random, but enough that they developed a single word to describe it. The median age of death is 41. And really the only definitive treatment for the congenital kind is a defibrillator, okay? What you'll see is this biphasic T wave. So if you see, there's this kind of down and up, all right? So that biphasic T wave is the type that you typically will see in the congenital kind. However, there are also a couple of others, this type 3 and this type 2, the type 2 being the more common of them, that causes this saddleback ST deformity, okay? If you think about it, it kind of looks like a horse's saddle that you would ride in. So that's why it's called that saddleback deformity. Those tend to be caused by medications. So some of the AV nodal blocking drugs will cause stuff like this. In those situations, they're not as at higher risk of developing VFib. So the treatment is we just take them off of those drugs and watch as it goes away. But typically don't need to progress on to have a pacer. Come on. Sorry, I don't know what's happening. Is that what it is? Good call. All right. Hypertrophic obstructive cardiomyopathy, or HOCM. This is a really devastating disease. Unfortunately, more than 50% of these have family, predilection. It's autosomal dominant, meaning only one of your parents needs to have this bad gene in order for you to get it. Essentially, what happens is this gene doesn't allow your heart to receive the signal that it needs to stop growing. So instead of your heart reaching kind of what its normal size is supposed to be, it just continues to grow and grow and grow. And it doesn't just grow on the outside, the septum continues to grow as well. So now you've got this big swollen septum and this big swollen heart. And because it's so big, it's become stiff. It's not able to contract as well. The septum is bulging, and so it may restrict the blood flow through the valves, et cetera. And so creates a lot of problems. Unfortunately, this is almost universally fatal unless the person can get a heart transplant. There's a family that I used to take care of that literally over a few years, I watched the mom, who was the first one in the family that they knew of who gotten it, watched her as she, went from normal and functioning to I think she was dead at 52. And both of her kids, unfortunately, also got the gene. So it was tragic having them watch what's going to happen to them if they can't get a heart transplant. The way you can tell this, or the way you can suspect it, is they'll have these massive QRS complexes. And it's because there's so much muscle there that there's that much more electricity. And so they'll have these massive spikes. It's not 100%. Like when you see an EKG like this, it does not necessarily mean they've got hypertrophic obstructive cardiomyopathy, but it should prompt the person to go get seen by their primary care, who can then, assess the need for an echocardiogram to take a look at the heart itself. But this is also one of the things that will cause sudden collapse in athletes. They'll exert, and then drop. And it's an undiagnosed cardiomyopathy like this. Electrolyte imbalances will cause all kinds of really funky things. So this is an EKG of somebody with hyperkalemia, and you can see, the QRSs are wide, the T waves are as peaked as you can get, et cetera. And in these other leads, it's kind of hard to tell what's a P wave, what's a T wave, or what's a QRS, and so on. So it gets this sine wave almost like appearance. All these other electrolytes will also cause weird things. So if you see an EKG that is weird in somebody who had something that was potentially symptomatic, it's probably a good idea to really strongly advise that person to come to the hospital with you so that we can take a look, because most of these we can fix, relatively easily with just some various infusions. All right, let's quickly talk about STEMIs. So when we talk about STEMIs, the stuff I have listed here are the American Heart Association's criteria for diagnosing it. I don't want you guys focusing on the bottom three, okay? Just focus on that top one. If you have suspicion that you have a STEMI, it is far safer for the patient if you activate the cath lab and get it wrong, okay? Because if you get it right, if you don't activate the cath lab and they're actually having a STEMI, you've just worsened their outcome. So super important that we get the cath lab activated early. If anybody barks at you for activating the cath lab, you bring it to me or Wendy, and we will make sure that that person is corrected about what we need to do. The cath labs have to have a certain number of false positives in order to stay accredited. They need to be wrong some of the time in order to stay accredited, because if we're getting it wrong, that means that we're hopefully capturing all the ones where it's a clear-cut STEMI. So this is an anterior. You can see the maximum ST elevations are kind of in that anterior area. Okay. We now move into a septal, where we see it's again, maximum ST elevations. We also see some reciprocal changes out here in 2, 3, and AVF. we see that reciprocal ST depression. A lateral MI, this one's a little subtle because we don't really see true ST elevation, out here in V6, but you get over here to 1 and AVL, and it's pretty clear that you've got ST elevations there. And reciprocal changes. We've got them in the inferior leads. We've also got them in the anterior and septal leads. And everybody's favorite, the inferior MI, all right, 2-3 AVF. We can clearly see ST elevations, okay? Don't really have much in the way of reciprocal changes. I mean, there maybe is a little bit kind of in the lateral. You can kind of see that ST depression, but not much else going on. And this is a posterior STEMI. So remember, electricity flowing towards the lead is a positive deflection. Electricity flowing away from the lead is negative, all right? So I want you to think about where V1 and V2 are. They're right on the front. So if we have electricity that is traveling away from it, okay, it's going to be a negative deflection. Well, what if we were to put those leads on the back? Now they're going to be ST elevations, right? So this is where having a strong suspicion, if you see ST depression in V1 or V2, you really need to do a posterior EKG and put V7, V8, V9 back there, because that may show you the ST elevation that you need in order to activate a cath lab. Personally, this one is so clear cut that this is a posterior STEMI that I wouldn't even necessarily bother getting the posterior EKG before activating. I would activate and then get the posterior EKG to confirm it. But you can see here, pretty massive ST depressions. So if we flip it, it will become ST elevations. All right, and this is a right-sided EKG. So, and again, in a right-sided EKG, the precordial leads have now been flipped. And so you can see, yep, we're having an inferior MI, and it follows that artery all the way down because we see the elevations continuing further down that artery. All right, so our treatment for STEMI is we really need to get this 12-lead EKG within 10 minutes of arrival. So this means like on shortness of breath and chest pain and things like that, we really need to be taking the monitor into the house with us, okay? We really need to be getting that 12-lead EKG in the house. If we can even pull it off, get it in the aisleway of Kroger, and get that 12-lead EKG, because it takes a few minutes for us to get packaged up and out to the truck. And that few minutes really does matter. There's now some literature that says that as little as 5 minutes between the balloon going up or not is all it takes to determine whether somebody is going to be a cardiac cripple or live a relatively normal life. 5 minutes. So that's why getting activated as early as possible so they can clear the table or they can get the people in from home is super, super, super important. Again, for us, it's a moot point. We only transport to cath lab hospitals for the most part. But if you're working someplace rural, you want to take them directly to a cath lab hospital, including by helicopter if needed. Aspirin is incredibly important. Aspirin, when chewed and taken promptly, has almost the same mortality benefit that the cardiac cath itself has. So super duper important. Even if somebody takes aspirin daily, they still need to take more aspirin. Their body kind of gets resistant to the aspirin. We can give nitroglycerin for pain control, but we don't want to do that in inferior MIs. Morphine and fentanyl may help with the pain, but there's some evidence that especially in inferior MI, it may worsen outcomes. It may increase the death rate. So not necessarily great. We only want to keep their oxygen saturation between 94 and 99%. we don't necessarily need to throw every single person on a non-rebreather. In fact, that can cause the arteries to spasm and make the ST elevations worse. So make sure that you get them to a normal pulse ox, not 100%. The overall goal is first medical contact, which is us, to the balloon being up in less than 90 minutes. And what a lot of hospitals have been striving for is less than 60 minutes. Again, because that 5 minutes difference has a world of effect on certain patients. So nitroglycerin for inferior MIs, don't do it. Questions? Obviously, I think only some of you guys have the ability to unmute yourselves and talk right now, but all right. So, what do we want to do? Do we want to play Jeopardy? Do we not want to play Jeopardy?
We'll do it because we got some medic students up here.
Awesome.
Oh, yeah.
All right. So
You want to do this?
got it. Okay. All right. So what you want to do is you want to go to this website, buzzin.live, and plug in that game code that you see. All right. You can pick your names. Please make them work appropriate of sorts. Theoretically, you know, we want it to be, since we got 4 stations here, 4 teams, but people are also welcome to play on their own. So one complaint I got when playing this the first time is folks were complaining that, well, their internet's faster than my internet. They're getting on first. So I actually read up on this website. It actually takes that into account. It knows how fast your phone is responding, and corrects for that when you buzz in. So yeah, if you're not buzzing in time, it's because of you. All right, so what we're gonna do is I'm gonna ask you guys to buzz in, okay? And let's make sure that it's working for everybody. So go ahead and buzz in. Okay, good. So now you get it, all right? All right, so we're going to play 4 teams. We've got 4 different things. So what we'll do is we'll play, and we'll make we're going to go just in order of where I think stations are. So we'll go with team 1 is the 86s, team 2 is the 87s, team 3 is the 88s, and team 4 is the 19s. Okay. We'll start with team 1, and the way this works is this is Jeopardy rules. All right. So you've got to phrase everything in a question, etc. You know, that kind of thing. don't blurt out the answer until I call on you, because we have to go back to that buzzer page to see where things are. Okay? All right, so clearing the buzzers. So 86s, what do you want to start with?
Treatment 300. 500.
Okay, I heard like 3 different things.
Just pick one.
Remember, buzz in. Okay. BH. Who's that? No, incorrect. Oh, sorry, wait a minute. Time out. Let's see, who is next? Mad Dog and me.
What is call medical control?
Okay, I guess I'll give you that.
No, wrong one. Team one.
Team one.
Oh,
we're-
sorry.
He said,
Let's see, change this. 86. I can't.
oh, was it good for the conflict?
All right, so what I was actually going for, but I'll give you credit for that one, because it is, if you're in doubt, you should call medical control, but it was introduce them to electricity. If you don't know what to do and they're unstable, introduce them to electricity, and a lot of the time it may bail you out. Okay? All right, so 86s, you are up still.
Anatomy 500.
Anatomy for 500. Okay, I cleared it. Don't buzz in. This is where the coronary blood flow originates. Okay, Mad Dog and me.
Inferior vena cava, what is?
Nope, incorrect. Yep. Price is Right rules, man. Junkyard dogs.
What is superior vena cava?
No. All right, so the correct answer is, what is the proximal aorta? Okay, remember that the aorta is coming out, and right off of it come the 2 coronary arteries. Okay,
How many did All right. Can you play this yesterday, Vinny? No, we didn't.
all right, so I believe 86s are still up because they had the last correct answer.
Match that rhythm 200.
Roly poly. Who's roly poly? Roly poly. Going once. Going twice. Okay. BH. Okay, yes. What is AFib? All right, good job. What you want? Okay. BH. Correct.
Bobby beat us.
So I'll give you credit for torsades, because this is kind of torsades with VFib.
You hear that? You give me credit.
You. Why didn't?
Cause I guess toward thoughts.
Hold on, did I give you credit for, yeah, I did. Okay, so you want 400? Okay, match that rhythm for 400. Let me clear the buzzer. All right, junkyard dogs.
Torsades.
Louder. Do it again.
Torsades.
All right, last warning for everybody. It's got to be in the form of a question. It's Jeopardy. Come on. Trebek would have said, nope, sorry. Must be in the form of a question. All right, let me clear the buzzers. All right, 19s, what do you want? Oh, come on, you can't, no.
What?
You're not allowed to buzz in before the question is even asked. What do you want?
Do treatment 400.
All right, Mad Dog and me.
The highest, what is the highest on the monitor?
Correct. Maximum energy available per manufacturer's recommendations. So I would have given you credit if you'd said 360 because that's what everybody around here uses. So let me clear the buzzer. All right. 86 is what do you want?
Basics 500.
Mad Dog and me.
Six. What is six? 60. I can't do the question thing.
But there were too many people talking. What is it?
What is 60?
Correct.
Six.
Somebody else.
All right. 86 is what do you want?
Basic 400.
Okay, junkyard dogs. That's what they did at Springfield, is they just started mashing on them. Junkyard dogs.
What is a QT interval?
Yes, good. Okay, what do you guys want?
Name that vessel 500.
Name that vessel for 500. Okay, junkyard dogs.
What is left anterior descent?
None of them. It's a trick question. I'll give you credit though, because we didn't talk about.
No. Oh, shit. No, that's cheating.
What is cheating?
So this is actually pericarditis. If you look, there's ST elevation throughout. Okay, so there's ST elevation in basically all of the leads. And that is indicative of this being pericarditis. So, all right, we'll not give them credit. We'll not give them points, but I would have. All right, so 19s, what do you want next?
Anatomy for 400.
This tissue helps move the electrical impulses quickly throughout the myocardium. Mad Dog and me.
What is cardiac tissue? I
No,
don't.
gotta be specific. So I believe the next one was junkyard dogs.
What is myocytes?
No. Station 87. Okay, so their answer is also incorrect. It's the Purkinje fibers. What do you think fibers are made out of? Tissue.
Nerves.
Not how Jeopardy works. And no, there are no daily doubles. That was another complaint I had when I did this with Springfield is no, there are no daily doubles. I can't even remember at this point who got the last answer correct. 19s. All right, 19s, you're up again.
The vessel 400.
What vessel is affected in this? Okay, Mad Dog and me.
What is anterior descending?
Correct. So the other answer that could be correct is the circumflex as well. Okay. All right. 86s, you're up.
What is basics 300? Basics 300.
Mad Dog and me.
What is the P wave?
Correct. Nerds. See, now the trash talking is starting. Wondering where it was going to be. All right. 86s, what's next?
Treatment 300.
Nitro.
Wow.
Nitro.
All right. Mad Dog and me.
What is nitro?
Correct.
Oh, yeah.
Who's this guy over here?
All right. 86s, you're up.
Match that rhythm 300.
Junkyard dogs.
What is SVT?
Correct.
Oh.
All right. 19s, what's next?
You can do the last match of rhythm.
I love how quickly people ring in on that. That makes me feel better. Mad Dog and me.
What is beta?
Correct. If anybody got that wrong, it was going to be up. Okay, now there's a complaint that it's technically it's wide complex and is it stable or unstable? Let's see. Clear buffers. Okay. 86s, you're up.
Basics 200.
Mad Dog and me.
What is 789?
Okay, I'll give you credit for that because there should have been a V, but that's good enough. All right, 86s.
Treatment 200.
Big over there.
Mad Dog and Me.
What is vagal maneuvers?
Yes.
Yes.
All right, 86s.
Treatment 100.
Junkyard Dogs.
What is aspirin?
Correct. All right, 19s, what do you want?
Anatomy 3.
Mad Dog and Me.
What is Wolf Parkinson White?
Correct.
Good job, Lydia.
Thanks. Thanks.
All right, 86s.
Basics 100.
Mad Dog and Me.
What is 2-3 AVF?
Correct.
Oh,
You lost.
Okay, 86s.
Anatomy 200.
Junkyard Dogs.
What is the AV node?
Correct. All right, 19s.
300.
Mad Dog and Me.
What is anterior septal?
No. Junkyard Dogs.
Uh-uh.
19s.
Time.
What's inferior? Is that what they're asking?
Yeah, it's named that vessel.
Oh, the vessel. Oh, inferior.
What was your answer?
Right coronary. What is the right coronary artery?
No. BH. No. Station 87. Turtle Town, is that
88.
that's the 88s? All right, 88s. Your moment to shine.
Circumflex.
No.
You have to ask it in a question.
Left main coronary artery. This is the tombstones that everybody gets worried about. So it's so high up that it's occluded both the left anterior descending and the circumflex. And so you get these massive tombstones throughout the precordial leads. And you get massive ST depressions in the inferior leads. All right. I can't remember who got it right last.
86s.
Anatomy 100.
Mad Dog and Me.
What is the SA node?
Correct.
Oh, yeah. Alright, we can just let it go. We're not gonna lose any point.
All right. 86s.
Name that vessel 200.
Junkyard dogs.
What is the left main?
No. Unfortunately. I don't think anybody else. BH. Correct anterior is left anterior descending. So it's not a left main because it still hasn't included the circumflex, which is why we don't really see much in the lateral. Okay. If it were including kind of the lateral leads, that would indicate a left main occlusion. So this is still in that left anterior descending.
Not at all.
All right, name that vessel. This is the last chance. Junkyard dogs.
What is the right coronary artery?
Correct. All right. So the winners are 86s, followed by the 19s, followed by the 87s and the 88s.
What did you win?
Shocker.
Lunch.
What do you win? My adoration. So, and I guess bragging rights that you won Cardiac Jeopardy.
No, we want lunch.
Pizzas.
Pizza party.
Beer.
All right. Thank you, everybody, for attending. Hopefully you got something out of this. Hopefully the Jeopardy was fun and worth it. Better than sitting through more lecture, in my opinion, but
Oh.
thank you, everybody, and we will see you later.
Thank you.
Yeah, we gotta reset our, our kids.